We are live.
Yeah. Thank you, Sunil. At the outset, I wish to give my heartfelt gratitude to the President, Dr. Partha, Dr. Santosh Hunawar, our General Secretary, and the Treasurer, Dr. Mathur, for readily agreeing to this, out-of-the-box IGO Journal Club. It's a new venture, and we thought we'll do it a little differently from the routine kind of webinars which happen. And there's a lot of discussion which is going on our OR sterilizing systems, the airflow laminar systems here. And I think we have some wonderful research which is emanating from the Indian background and from one of the leading high volume centers of our country. And so we thought we'll just put in the leading speakers who are perhaps the best of the academic minds in this center. And we have with us in line one of the best lineup of all the ophthalmic personals in this field who would give in their inputs. And also with us is Mr. Vinod, who is also a HVAC engineer. So he's also going to be the only non-ophthalmology. He's got an engineer who's going to give us a feedback into it. All the others here are well-known names, do not need any special introductions here. And I extend my heartfelt thanks for taking out time the next 1.5 to 2 hours to discuss this issue on understanding the OT sterilizing systems better. And I would now hand over the podium to Dr. Kumaran. I think Nirmal and Kumaran have been widely speaking on this on their hospital accreditation, practice management systems, OT sterilizations for a long time. So over to you to Kumaran and to introduce and invite Dr. Nirmal for his talk.
Thank you, Dr. Vanati, for this wonderful opportunity. Yes, this is definitely a different kind of journal club, and this is a hot topic as for now, with so many operation theaters coming up everywhere. See, around 2 decades back, my professor used to tell me, of course, humorously, that they used to operate under a tree also. So we have come under a long way where operations were performed in makeshift operation theaters during camps. And now we have a full kind of tertiary hospital set up with a HVAC system in place. And the primary objective of any operation theater, as we all know, is to maintain the sterility, keep the patient infection free, at the same time also to provide comfort to the surgical team. And we all know that the only way to provide this is to regulate the temperature, the particulate count, and the humidity by incorporating a well-defined HVAC system. This has been recognized even by the WHO, and the government of India in its latest guidelines has mandated an HVAC system to be in place. However, a landmark paper from Aravind Eye Care system with its huge volume of surgery has definitely sparkled the debate benefiting questioning the benefit of the HVAC system, because a cataract surgery is only a very small wound size and is only for 5 minutes. But it is to remember, but important to remember that the air quality is not the same throughout India. For example, so if I'm going to keep a loaf of bread outside in Chennai, it could probably develop a mold in 2 days. But the same would be different in Kashmir or a different place where it could remain fresh even for weeks. So this is to state that the air quality is different. So with this background, I would like to invite Dr. Nirmal, who is a pioneer of quality care in India, who's been instrumental in bringing out the eye care standards. He recently has brought in the second edition of eye care standards and who's synonymous with quality. He's director of Nirmal Eye Care Hospital, it's a tertiary care hospital in Chennai, to give and share further insight about the benefits of the HVAC system in ophthalmic theaters. So over to you, Dr. Nirmal.
Thank you, Kumaran. And the outset, thank Dr. Vanati and the AOS leadership and all my colleagues here for this wonderful opportunity. Let me share the screen. So to start with the journal club, I heard this is the first journal club of this kind from the IJO. So happy to be the opening batsman. And so any journal club starts with what is fundamentally available and what research or new thoughts is challenging this fundamental principle. So there are something fundamental to our practice, the standard that govern our operating theatres and why they matter more than we might initially realize. So as a surgeon, we demand precision in every instrument, every technique, every procedure. But how often do we apply that same scrutiny to the environment in which we operate? So today we'll explore why the infrastructure surrounding our surgical practice just as critical as the surgery itself. So these are the foundations, 7 essential principles. Do no harm, the cornerstone of medical practice. And we all know prevention is better than ounce of care or cure because always more effective, cost effective, and gives a wonderful return on investment. The regulations and guidelines, they exist for us, for our safety and our patient safety. The hierarchy of infection control methods. So this has been time tested, proven worldwide that engineer controls is one of the cornerstone in the hierarchy of infection control methods. And at source reduction of errors or infection is the most important principle in infection control. And identify root cause and eliminate the root cause remains the fundamental principle of quality. And we also have to acknowledge we must meet the same standard that of the entire healthcare spectrum. We can't be living in a world of our own. So what is standardization of healthcare facility? This is an important strategy in healthcare facility design because standardized clinical areas promote efficiency. People who are running the large institutions would know that standardization and reducing the variability is the most important step in reducing the risk to patient care. And it makes life easier for the administrators, clinical staff, and reduce incidence of medical error. And if it's identical OT, the work efficiency improves and it's cost effective and maintenance easier over the long period. Modification and integration in the future is important if standardization can be done because want of parts or restoration or renovation is easier. And standard of care, of course, medico-legally starts with standard of infrastructure. So with this basic principle in mind, I'll touch upon the fundamental 3 dimensions of quality of care. So structure, process, outcome. This is a Donabedian model which provides us with a clear framework for understanding quality of care. So if there is good structure, including proper infrastructure, qualified staff, and adequate funding, it increases the likelihood of good processes. And good processes in turn affects the outcome. And obviously, if there is good structure and process, the outcomes are far better. So this isn't an abstract theory. So this has been practiced worldwide over 100 years now. So when we examine our operation theaters, we must ask, does our structure support excellent processes and optimal outcome? So let me share a powerful analogy from the public health expert, Dennis Burkitt. So if people are falling over the edge of a cliff and sustaining injuries, the problem could be dealt with by stationing ambulances at the bottom or erecting a fence at the top. Unfortunately, we put far too much effort into provision of ambulances and far too little into the simple approach of erecting fences. This is what quality standards advise, focus on root cause and prevention. So we need fences at the top of cliffs rather than more ambulances at the bottom. So let's build fence first and later station the ambulances. So let me come to the role of engineering controls in compliance requirement. So we all know infection caused by airborne microorganism is a complex mixture of engineering, particle physics, microbiology, and of course a little bit of medicine. And the rate at which particles settle are a function of their size, shape, density, and of course air movement. So COVID taught us this just a few years back in a big way and in the negative way. So what is the engineering controls or engineering design in accordance with the acceptable guidelines? So of course, heating or cooling depends on the area where we practice. Ventilation is very important and air conditioning, including pressurization type. So we'll be focusing on these top 3. Apart from that, So there are certain engineering controls which is necessary for infrastructure like the operation theater, the power outlets, lighting, sterilization, the sanitary and other fixture, medical gas outlets, and of course, surveillance and monitoring is important. And of these, the engineering control in operation theater also focus on not only the AC ducts, filters, cleaning replacement of filter, but also the plumbing and air water supply, because any deviation in these two aspects can lead to a big negative impact. So this is the hierarchy of infections. If you see, the most effective is elimination. Of course, very difficult with elimination of microorganisms. And the next in command is the engineering control. So this is where all this HVAC system come into the picture. And then our administrative controls are managerial controls. And the least effective and most costly, the recurrent cost is the PPE, and which is the least reliable. So unfortunately, we focus more on PPE, which is the end users thing, rather than engineering controls, which is the most reliable and least most effective one. So before going into this, what are the statutory requirement and current guidelines of India? So we need to introspect and see why the legal regulations are very stringent. And so unfortunately, there's a lack of proper administrative mechanism to oversee this. The current standards are focused or based on these legal requirements. The National Building Code of India, which was revised again in 2016, where HVAC system should add to the safety, infection control, and easy maintenance of public health buildings. This is also specific for Type C, where hospitals are part of the this classification. And this is the NBC Section 8 HVAC norms. So where the entire chapter is focused on planning, designing air conditioning, noise and vibration control, the mechanical ventilation for non-air conditioned area, and the role of split air conditioners, package air conditioners. All these are dealt with under the NBC Section 8. And this next guideline is the guideline issued by the Ministry of Health and Family Welfare. So this was again revised in 22 following the COVID. Healthcare associated infection prevention. So there is inbuilt environment regulations, engineering controls for sterile areas. And also it prescribes surveillance and monitoring protocols. And of course, the Indian Health Facility Guidelines, Part D focus on infection control, the IPHS standard, the IS standards, Part 1, 2, Part 3. And then there is a guidance note from the American Society of Heating, Refrigerating and Air Conditioning Engineers called ASHRAE. And we have the Indian counterpart, Indian Society of Heating, Refrigerating and Air Conditioning Engineers. So they have issued these guidelines even recently, 2 years back, it was amended. And the hospital shall ensure that heating, ventilation and air conditioning shall protect the environment and not contaminate the environment in any form, which means, so we have to resist the usage of a lot of disinfectants. And these are the Environmental Protection Acts. I will not go into the details, but the carbon dioxide monitoring of indoor air quality is one of the norms prescribed by the Pollution Control Board. And the sixth important thing is the Gazetted Clinical Establishment Act, which we are mandated to follow by the establishment. And this prescribes not only the size, scope of theatre, but also zoning is very, very important because it's part of the Gazetted note. And you see that 4, 5, 6 air conditioning to provide in all areas. Window AC and split units should preferably be avoided as they are pure recirculating units and become a source of infection. So this has been gazetted, and which means that it has a legal provisions. Temperature and humidity in the OT shall be monitored. So these are the statutory guidelines. So this is also part of the minimum requirements for a procedure room. We need to give adequate space for not only for men machine, but also for the other support areas. And of course, the BIS standard, which is the basic of all standards, so has given this recent outline. No recirculated air in operation theaters. Temperature and humidity control is required. Safe refrigerant only, non-explosive chemicals, and fresh air systems mandatory. And now NABH, as a part of the international and national statutory regulations, has to follow the health ministry guidelines, follow patient safety standards and goals, And of course, since health is a state subject in India, we have to follow the gazetted clinical establishment rules as well. So where we stand? So we blame the arrow instead of the archer, because the arrow here is only the NABH, which ensure that regulations are part of its standard. But unfortunately, the standards get criticized for outdated regulation it must legally follow. The Parliament of India enacts laws, mandates the Bureau of Indian Standard to be adhered. This defines state licensing authorities, which compels the standard accreditation bodies to incorporate all these things. So as an accreditation body, we cannot ignore existing legal licensing requirement. So what is the intent of NABH standard? To provide safe and secure area for patients, plans for fire and non-fire emergencies within the OT, which is a critical area, and also have a program for clinical and support service equipment for our highly funded, highly costly equipments. So these are two important chapters in the NABH standard: hospital infection control, the facility management, and safety. So these two important chapters form the basis of my presentation here. As I said earlier, structure is important to have a good process, and good process are important to have very good outcomes. And in I center, the only critical area is the operation theater. That's why we need to focus more on the location, how it is utilized or optimized for our patients and providers. And also we need to take into consideration the long-time exposure to poor air quality, chemicals, ultraviolet rays, the ETO and other gases we are exposed to in the operation theater. So in ophthalmic theaters, being very small in size, there are a lot of challenges. One is how to provide the safe, comfortable, relaxing environment, and how do we safeguard the care providers who spend a lot of time in the operation theater, and of course, infection control with the important zoning, equipment, ventilation, and unidirectional flow. And this unidirectional flow of men, material, resources is an important principle where mixing of sterile and unsterile products and consumables can be prevented. And this is an important thing. So what is the scientific foundation of accreditation standard? I've already told you about the legal standards and the guidelines, but this operation theater guidelines were formulated over a period of time between 2015 to 2024. A lot of changes have happened with a team of infectious disease specialists, biomedical engineers, microbiologists, surgeons, and of course, HVAC engineers. We have one engineer with us today who will throw light on this. So this is the revised guideline for air conditioning in operation theater. So basically, there are two types of theater. Type A is the super specialty OT, and type B is the general OT. Ophthalmology, daycare come under the general OT norms. And for OT standard, the basic assumption kept in view. We also need to have, so whenever we talk about standard, so this is the basic assumptions. The standard occupancy of one patient, 5 to 8% in the surgical team at any given point of time. Unfortunately, many of our theater has at least double the amount of occupants in the theater at any point of time. Standard equipment load of 5 to 7 kilowatts, which includes the operation microscope, the Boyle's apparatus, and the lighting systems, and ambient temperature and humidity at each location to be considered while designing the system. So what are the ideal parameters? Continuous air purifying, temperature, optimal temperature between 20 to 23 degree, relative humidity. So our country has a varying humidity across the various geographical locations. So we need to ensure these parameters are integrated into the day-to-day functioning of our theater. Air movements from clean to less clean areas and air changes. So minimum 15 total air changes per hour. And this has a scientific rationale because the particle clearance time, 99% removal in 12 minutes, and HEPA filtration, most penetrating particle size are filtered by the HEPA, and positive pressurization really helps in blocking the ingress from the corridors, maintain sterile hierarchy, and rapid pressure recovery. I already told you about the hierarchy of effectiveness. Elimination is very important. So removing the contamination sources by clean air, replacing it with the clean air, and the continuous environmental management of fresh air coming into the system is important. And of course, administrative control and PP are last line of defense. We can't be dependent on human compliance. We all know how difficult it is to believe our staff. So why engineering controls are primary? Because they are independent from human factors. It works regardless of staff behavior, and it offers continuous protection versus intermittent chemical treatment like fogging or the split air conditioning. And real-time monitoring is possible and valid can be validated. Whereas on the other hand, the split AC environment contamination accumulates unchecked, whereas AHU maintains sterile conditions automatically. So how does HVAC help? I know ophthalmologists maybe may not be understanding these basics. So whenever air is pumped, so it actually dilutes by ventilation. It improves the air quality by filtration, and exposure time varies. It reduces the exposure time to microorganisms. The temperature and humidity are important parameters. I'll touch upon this later. And here, there is no chemical involved in HVAC system. Only the air is being used to disinfect. And so I will not go into the fundamentals of AHU. It's basically a unit where the outdoor air is pushed in to the theater through filters and through effective heating or cooling mechanism. And this is the inside of AHU. So this helps in two regulations. One is temperature regulation and also regulates the relative humidity. And so NABH prescribes a dedicated AHU for each OT so that there is no mixing and no linkage with other areas and no split or window AC permitted. It is just a continuation of the legal norms in the Clinical Establishment Act. And we also need to monitor this system. So these are the critical compliance points, and we need to monitor the particle count and also system validation, and pressure differential has to be monitored. So why humidity control? Because low relative humidity is suitable for Klebsiella pneumonia activity. High humidity, which is a problem in our part of the world, it enhances the growth of Pseudomonas. If you link Pseudomonas, it's one of the common contaminant in cluster endophthalmitis. And so we need to maintain this humidity so that we ensure it is not a potential ground for microorganism to grow. Positive pressure ventilation ensure 1 to 2 plus pressure differential so that external air particle does not come in, and this forms a barrier. And what is the alternative available? So we have window or split air conditioning using for so many decades, and of course chemical disinfection like fogging or surface disinfection. But if you take the history of usage of disinfectant in our country, it's overkill. And this actually is hazardous. So why AHU should be dedicated one, and window split AC should not be used in any type of OT because of this recirculation and convenient pockets for microbial growth, which can't be sealed or accessed by human hand. So this is how some of the ACs look like during our NABH inspection. And these are fundamental design deficiency in the split ACs. So recirculation without adequate filtration. So 30 to 45% efficiency. So it even though there are so many filters, the efficiency is only for large particles. And over a period of time, there is bacterial accumulation, progressive concentration over time, and biofilms forms in the drain pans, coils, and ductwork. These are very difficult to reach by our staff. And this acts as the convenient pocket of microbial growth, like Pseudomonas aeruginosa. And of course, the evaporator coil contamination is one of the important deficiencies in this kind of split air or window air conditioning mechanism. And coming to the chemical disinfection, this is an unreliable safety net. There are fundamental limitations on the chemical usage. The contact time varies, so the efficacy also varies. The surface coverage cannot reach airborne pathogens. And also there are shadowing effects. Protected areas remain contaminated. And over a period of time, once we start functioning in the OT, there is rapid degradation in the air. And of course, we all know the resistance development to quaternary ammonium compound and alcohol, even though we've been using for 100 years now, evaporation before adequate contact is the rule with current spirit or the alcohol mechanisms. And hydrogen peroxide has limited airborne penetrations. And of course, exposure to hazardous chemicals is injurious not only to patients, but also to the providers who are far more exposed than the patients. Patients themselves are here only for 1 or 2 hours, whereas we ourselves are exposed to this hazardous chemicals in the health sector. And particularly, there's a 67% risk of new onset asthma in nurses, and glutathione have been associated with double the risk of asthma in the healthcare providers. So this is an overview of hazardous chemicals, allergic reaction, organ damage, CNS impairment, eye irritation, lung injury, and cancer, and oxidative damage which leads to cancer. So there are human factor risk because chemical usage depends on the concentration, depends on how it is applied, depends on the contact time. Of course, there are product shortages which can disrupt the protocols. So, and also validation is very difficult with chemicals because the indicator organism may not represent actual pathogens.
Dr.
And,
Nirmal,
chemical.
Dr. Nirmal, I think we can wind up and now move on because it makes it more precise to focus on what we are going to be discussing.
Okay,
Yeah,
just
sure.
last few
Yes.
slides. So international standards alignment. So I will not go into the details, but basically all standards say mechanical ventilation with appropriate filtration represent the most effective method of controlling airborne contamination, and chemical disinfection has only a supplementary role. So if I'm lying on this operation table, what do I want? So this is a message for hospital leaders, promoters, designers. They should ask themselves, safe infrastructure or poor quality air around me, or a lowest price substandard structure above me. So the very first requirement, you all know, so can we look our patients into the eye and tell them we provided the safest possible environment for their surgery? With current mechanisms, split AC systems, and concoctions of chemicals, the honest answer is no. We also need to take into the regulatory reality before looking at the standards aspect, because unless the regulatory updation happens, the standards cannot update itself. So the current evidence speaks, engineering controls are reliable, validation independent infection prevention, and as ophthalmologists, we demand precision in our surgical equipment and technique. We must also demand equal precision in our surgical environment. So we need to have optimization. We need to follow legal requirement, reduce medical surgical errors, and over a period of time, maintenance becomes easy and cheap once we understand the mechanism and take the help of the engineers to have well-designed, optimized sorting. So we need fences at the top of cliffs rather than more ambulances at the bottom. Thank you.
Thank you, Dr. Nirmal. That's a wonderful presentation, a very detailed one too. So from your presentation, I understand that the air is also an instrument which has to be sterilized like any other instrument in the operation theater. And you have perfectly highlighted the importance of bringing in a standardization by bringing an HVAC system. And the other thing is eliminating the pathogen at source. So it'll be interesting to get some panel discussions on one interesting factor which you had highlighted, the measuring of carbon dioxide inside an operation room. So I don't think a lot of HVAC engineers do mandate this, but I feel that the carbon dioxide content in a closed environment without air changes is going to really go high. And when we talk about reducing the carbon load, this buildup of carbon dioxide inside a theater without an HVAC system, how important so is? So I would like to take the views of our HVAC engineer, Dr. Vinod, followed by Dr. Nirmal and Dr. Samina to talk on this topic.
Thank you, Dr. Kumaran, and thanks, Dr. Nirmal, for the good presentation. Coming to the air, I mean, I talk about, whenever I talk about 2 points. One is prevention is better than cure, and next is air with care. So that talks about the air and the environment inside the theater. As when we look at the number of people inside the theater, generally the standards talk about 5 to 7 or 5 to 8, but invariably during any surgical operation, generally we have more people. So though it's not mandated to say that CO2 is to be measured or oxygen level is to be measured, what happens is the air change per hour becomes important, which talks about dilution, which talks about contamination control. So that takes care of this carbon dioxide removal as well. Because when we go for an air handling unit, that is capable of taking in fresh air. That's capable of taking in fresh air, which actually comes in and brings in the overall air changes per hour. And that air changes per hour over a period of time starts diluting the contamination level within the operation room. So this dilution happens to the carbon dioxide level as well. Now, what happens when the AHU is going to work? Not only it takes in the fresh air, it brings in the air change per hour also, but it has got a deeper row coil through which the refrigerant gas is passing. What happens when the air passes through the coil? It not only gets the temperature not only tempers down, it also reduces the humidity. Basically, the condensate water is collected. When you look at a split air conditioning unit, the indoor unit has a two-row coil. Whereas when you go for an air handling unit, the air handling unit coil can be customized. It can go up to 10 rows, depending upon the kind of humidity that you really want inside your operation theater. I just can give an example of a pharmaceutical industry where they manufacture tablets. Humidity level goes down up to 35%. So there, multiple level of coils and multiple level of reheating systems or dehumidification systems are brought in. This condensation, which gets out of the room, obviously brings down the contamination levels in the theater. So I just started on the carbon dioxide quantity level, the amount of fresh air coming into the theater, the amount of air change per hour. So that's the reason, after so many studies, they have maintained a fresh air incoming component of 4 air change per hour. That air change per hour multiplied by the volume will know what is the CFM of air required. Now that does not happen when you have a split air conditioning system, because it becomes a purely recirculating system where the air gets circulated over and over within itself. So the fresh air component doesn't come in. So obviously your carbon dioxide level increases. So that is the way where the carbon dioxide level becomes a challenge to you. But
Understand.
indirectly, when you use an air handling unit with fresh air and the component of air changes per hour, carbon dioxide level gets controlled. The filtration level also gets controlled.
So it's not mandated to measure the carbon dioxide content because the air changes itself will take care of it.
Yeah.
So that is the final.
Exactly. One more
Okay.
point which I wanted to talk about, Doctor, is the filtration levels. When it comes to the filtration levels, because contaminations keep on coming into the theater because we movement, we bring in a lot of materials from outside. So all of them keep on bringing in particles which are contamination prone into the environment inside the theater. So what happens is, when we look about the filtration level, the split air conditioner has only a 10 micron filtration level. But when we talk about high-end filtration, we need to have up to 0.5 micron and 0.3 micron when it comes with the usage of HEPA filters. The air handling unit itself can come up to 0.5 micron, which means it has got 2 levels of filtration, which is the first level, which is the pre-filter, which is 10 microns, and the fine filter, which varies from 0.1 to 0.5. So that is important for us to dilute the amount of contaminations that gets generated inside the theater, gets brought in from outside when we bring in people and materials coming into the theater. The last
I
level of
understand.
filtration becomes your HEPA filters.
Good, sir.
Yeah.
So thank you for your inputs on it, Dr. Vinod. Dr. Nirmal, I have a question for you. So you had shared all the legal requirements as far as HVAC system is concerned. Does this vary according to different states as far as the Clinical Establishment Act is concerned? Does an HVAC system is mandated in CA also?
I think Kumaran, before that, I think Dr. Savitri she had raised her hand.
Yeah.
Dr. Savitri, yes.
Yes,
So
madam.
I had a question for Vinod actually. I would think that the humidity also would go up in a air-conditioned area which is recirculating the air and there is no air exchange. So does he agree with that, Vinod?
Savitri ma'am, I'll just mention like this. When you close the door and when you don't have any infiltration happening, the inbuilt heat coming from the people, the equipments, will reheat the environment. But what happens is, when we use a split air conditioner with only 2-row coil, it itself cannot control the humidity. The humidity level generally in a theater will remain around 70 to 80% if you use a split air conditioner. But yeah, the usage of an air handling unit which has got a 4-row to 6-row coil, in spite of bringing in fresh air which is high humid, still reduces the humidity. Now,
Yeah.
when it comes to the certain level that we have to bring in up to 50%, we add a reheater battery into it. We add heating into it. So that heating element is the one which finally brings down from 60 to 50%. As like how Dr. Nirmal said, the development of organisms do happen or they thrive when it's high humid. So indirectly, when you bring down the humidity, the contamination further drops. So
Yeah.
coming to 50 to 55%, because my question always has been there, if I sit in front of the operation theater room, you can imagine the number of times the door is being opened. The
Yes.
number of times the infiltration is going to happen, the number of times the ingress of air is going to happen. And now across India, it's rainy season. You can imagine what is the level of humidity just in the sterile corridor itself. Forget the semi-sterile. So this sterile corridor is going to bring in the humidity into the theater. Now, coming to the AHU, AHU has got a high static fan, whereas a split AC has got a low static fan. A high static fan is one which can push the air through all the filters. A low static fan like a split AC can only handle 10 micron filters, but an AHU can handle up to 0.3 micron filters. Now that high static pressure finally gives you the positive pressure in the room as well.
Yeah.
Okay, that reduces the ingress of air, reduces the ingress of humidity. Overall, efficiency keeps on increasing because as how very aptly Dr. Nirmal said, it is a standalone equipment. No human interface is required unless somebody goes and tampers with that temperature setting. And if you have an automatic control, it's going to be there forever. I hope it's clear, Dr. Sabitri.
Yes, ma'am.
Yeah.
Dr. Nirmal, regarding the CEA mandates, the HVAC system, is it same for all states or does it vary accordingly?
It varies, Kumaran. The central law is what I posted in the presentation. So it just says you need to maintain the zoning, you need to maintain the humidity and temperature, and the recirculating units are not prescriptive, right? And many of the states, 19 states have adopted it, and all the union territories have adopted it, being a central act. So which means 75% of the country is already under this guidelines. It is not prescribing AHU, but on the other hand, in the negative connotation, it says chemical disinfection to be avoided, and we need to maintain these parameters. I'm sure Vinod will agree with the split or window ACs. We cannot maintain these parameters. So that is the difficulty with the current system.
So
I
we'll
do
take
agree, sir.
Okay. I will take a few more questions before we move on to the next session. I would like Dr. Samina and Dr. Gagan to say whether, see, we only talk about the infection control, but does bringing an HVAC system in place add an additional a level of comfort to the surgical team? Do you feel it's a very significant factor or not? I would like Dr. Gagan and Samina to answer this. Dr. Samina?
Yeah, thanks, Kumran. I think I would completely agree with that the comfort level would increase. And as Dr. Nirmal very beautifully said, that it all depends on the structure, process, and the outcome. So if the structure is in place, the processes will also flow. For example, there is a key performance indicator, what we have in our OT, that the number of times the OT door was opened after the surgery started. So, and people going in and out is controlled. The doors are hermetically sealed, so the positive pressure is maintained. And there is at all levels, the surgeon is more comfortable in an environment which has an air handling unit. So I would very safely say that if your structure allows and besides the good sterilization system, the only one thing which your OT needs is an air handling unit. Yeah. Thank you.
Dr. Gagan, do you feel that an HVAC system is going to benefit in a way that it could safeguard our instruments and the other things? Do you feel that it is really beneficial?
Yeah, so summing up, not going into certain other controversial things which we are going to discuss later, yes, it will be more comfortable because your temperature and humidity is controlled. So as a surgeon, you have already scrubbed up and you are gowned. And when we operate in different OTs, you will realize that in some you are not comfortable. You might be sweating in certain cases. So yes, it's a more comfortable and controlled environment. So you really can have drapes, and for the patient also, because patient is draped. So if you have kind of a variation in humidity and temperature, sometimes it might be uncomfortable for the patient as well. So a controlled environment, you can really have things which go with that because you are in the range of humidity and temperature. And with a split AC, the humidity varies, and it will vary during the course of when it's running, unless you really add up certain other measures. Other thing would be, if you're not using AHU, you are going to fog the OT. So fogging again is use of chemicals. Fogging will take time. After fogging, you will have to have some time before you can start your OT. And your staff is going to be, exposed to the chemicals also with the range. So it will again depend upon who's using what. So that's variation is there for the staff as well as your OT. Plus, in case right now, if you really want to run your OT efficiently, maybe you may not have the time. Right now, if you have an emergency case, your OT might not be ready to take in that case. So an OT where you will have to have lots of planning in terms of this thing. Fogging and a split AC, the OT may not be ready immediately. You may have to plan for many things and cleaning and all things. Other factor would be with fogging, you cannot move everything outside the OT. So the fogging is definitely based on chemical going to discolor your equipment, the exteriors of equipment, lights and whatever, they will kind of, always have those deposits of what you're using. Your microscopes also are covering, but still something will go. So yes, there is some impact. And, if the staff is careless, they may actually end up, not covering certain things which you want to, you may have some deposit on your lenses, the lens in the microscope and other things. And one important thing, what's happening now, and I think so all of us would have seen, with variation in humidity, we have lots of electronics in our equipment now. So a very common example is in your home, the LCD TVs are going off in a high equipment because it kind of condenses inside and the circuit, short circuits. So wherever our equipment is getting all these touch panels and more electronics to that, they are very sensitive to certain chemicals while fogging, which might enter inside because they have heat dissipation points where they are open, they don't have a filter there, or a high humidity might, condense or affect those things. So a mechanical old equipment was really not so sensitive to this factor, but even our household equipments now in many areas is very sensitive to the, a seepage in a wall or a high humidity content where our TVs are conking off. So that will be another equipment saving thing that, your equipment may be sensitive, and particularly the display and, the circuit boards of certain equipment which you use.
So that's a very important point which you highlighted, Gagan, that eliminating fogging in a HVAC system is really going to increase the life of your instruments. So we have really the other important questions to discuss, but I think I hand over to Dr. Vanati to invite Dr. RDR for his presentation, and then we'll have a few more questions for the panel.
Yeah, thank you, Kumaran. And I think before we move on to the most wanted, talk what we want to learn from the Aravind experience, may I ask, invite Professor Radhika Tandon again. She's heading the ophthalmic center at AIIMS in New Delhi here, and I think we are one of the centers who are doing a very high volume surgery, and this door opening and closing is really a concern. So any points which you would like to add on, Dr. Radhika Tandon?
Yes, thank you, Dr. Vanati. So first, I'd like to appreciate all the points that have been made. Very nice, clear concepts and also clear guidelines have been shared. And it's very important that everybody in the chain is aware of these restrictions because there's one thing to have an AHU, but at the same time, if, as you correctly said, the staff doesn't understand the concepts and they unnecessarily keep coming in and going out and unnecessarily bringing things inside and disrupting the flow, that adds an element which is out of your control. The other thing which has also been touched upon lightly is to move to the stage that you don't count so much on the staff. Like one option is there that you have somebody who monitors how many times the door opens and closes, but apart from that, you can have some kind of electronic monitoring of this and some kind of inbuilt system that if supposing there is an excess flow in and out, then there can be a gentle alarm or some kind of a light which comes on. Obviously, you don't want to alarm the patients, but some kind of a warning light, some kind of a further electronic or engineering checks and balances can be added. The point about the crowding is definitely there, and often OTs can, if you see why should there be more than a certain number of people inside the room. So there again, the teams should look into better processes, better flow. If it's just a question of, learning the procedure, there could be a video monitor outside for other people who are just observers. They don't have to be physically present in the OT all the time. So these are other things that obviously there is a cost and all involved. But yes, this is the way that we should start thinking, because after all, there is a concern about infection control, and all these principles we need to keep in mind within practical feasibility from center to center.
Yeah. Thank you very much, ma'am, for your inputs now. And now we will move on to learn from the Aravind experience. Dr. Ravindran has been a phenomenal teacher. I had the extreme privilege of working under him directly and learning from him so many aspects. He's not only an excellent academician, a wonderful surgeon, he's also a great human being, and he's a teacher in all aspects of ophthalmology and life. Thank you, sir, for this opportunity to be on the same podium with you. And I invite you to enlighten us with the Aravind experience and how perhaps your experience can help several establishments who probably are not able to get into the international structured requirements for OT standards, and how this is probably going to influence our practice patterns. Over to you, sir, Dr. Ravindran.
Thank you. Just give me a minute. I'll share the slides. Hope you can see the slides and my voice is clear.
Yes, sir.
Okay. I mean, this is a paper we had recently published along with some of our friends and colleagues from New York, USA, and also from California and from Virginia State in USA, because they had some interest now to show that that the laminar airflow with the HEPA filters may not really contribute to infection control in cataract surgery. So that is a presumption on which they wanted to work with us. And as you all are aware, I mean, as we just heard, the laminar airflow, it is fitted with high efficiency particulate air filters are supposed to improve the reduce infection rate. I mean, this has come basically from some of the studies which were done earlier in patients who underwent surgery, especially in orthopedics. And there was a paper published in the year 1987, which showed that AHUs which are fitted with laminar airflow and HEPA filters reduce the surgical site infection. But on the contrary, there have also been several publications, one of which I put up here from Germany, where it was a retrospective study. They found there is no benefit of having a laminar airflow status even in abdominal and orthopedic procedures. And most of the studies we have, except one study which is again from India, we don't have any studies based on the laminar airflow and HEPA filters usage in reducing the infection rate in ophthalmic surgery. And interestingly, Aravind started in the year 1976. In the last 45, 50 years, we had started hospitals at different point of time. And all these hospitals, I mean, as we start a new hospital, we try to comply with whatever the statutory norms. And in that way, the new hospitals, about 5 of them, have a laminar airflow with a HEPA filter. And about 3 of them, which were built earlier to this period, before 2017, had a central air conditioning with HEPA filter system. And before that period, so before 2010, we had 2003, we have 2 locations where we have central air conditioning, but without any HEPA filter. And some of the hospitals which are built in the rural areas, secondary centers, during this period, even after 2003, were all provided with a HEPA filter. So we have a very even though we have 14 hospitals, we have 17 surgical facilities with varying types of air conditioning system. So the whole purpose of this study is to determine whether using this laminar airflow with high efficiency particulate filters, does it help in reducing the rate of surgical post-operative endophthalmitis is the main purpose of the study or the publication. So we looked at about 452,000 cataract surgeries performed across these 14 hospitals during one calendar year. During 12 months, we have taken about 23. And the study design it's a retrospective study where we looked at all patients who were operated in these 14 locations from 1st December to 1st January to 31st December 2023. And we have a good electronic medical record, and we have a way of capturing this and also populating in a cataract surgery database, which we review on a regular basis. And we as an organization, we have a reasonably good standardized surgical and perioperative protocols in all the locations. So we have grouped them into 4 groups. The group 1 is the 5 hospitals, 5 facilities which had laminar airflow with HEPA filter. There's a group 2 which had central air conditioning with HEPA filter, but there is no laminar airflow. The third group is central air conditioning without HEPA filter, and 4 we have a split AC. As you are aware, they do not have a HEPA filter, and they can, as mentioned earlier, they can filter only particles up to 10 microns. And we also did some sub-analysis to understand its impact of all these AHUs on phaco versus small incision cataract surgery, and also with regard to the pain status of the patient. So, and we have a standard cleaning protocol for all our operating rooms, especially the air conditioning systems, because we know the importance to minimize, to get the best out of it. Maintenance is very important. So the first stage pre-filter is always clean on a weekly basis. The second stage filters or micro filters are cleaned once in 2 months. So this is what we do wherever we have the AHUs, and where we have HEPA filters, and we change them typically once in 2 years. Usually within 2 years it is all changed. Sometimes it may be earlier based on the recommendation of the validating agency. And the split air conditioners, we pay a very specific attention. The filters are cleaned every week, and then a complete wash. We completely dismantle the whole split air conditioner. Like you saw a picture shown by Dr. Nirmal Frederick. If you don't do that, if you don't do this cleaning on a periodic basis, that is where we'll end up. So here, the whole thing is dismantled, and we have the agencies who do this complete water wash. So there is a reasonably standardized protocol which is followed across all hospitals. And again, coming to the infection protocol, we do regularly check the duct, and we also instill preoperative antibiotics. We use ofloxacin 0.3% across all hospitals, and that is also continued for about 10 days after surgery. After 10 days, it is discontinued, and we use povidone iodine both outside around the eye and also the conjunctival sac. And again, we use intraoperative intracameral injection of moxifloxacin for 500 micrograms in 0.1 ml at the end of the surgery, and the patients are given dexamethasone eye drops 0.1% for about 6 weeks. And based on the clinical findings, we make a diagnosis of endophthalmitis, especially all patients, whether they undergo or not. If they have been diagnosed to have endophthalmitis and we have advised any intracameral or intravitreal antibiotics or vitrectomy, these patients were included for the study. And again, all the patients who are endophthalmitis up to a period of 90 days or 3 months following cataract surgery is included. But typically, if you see most of the publications in the literature, they take into account only about 6 weeks, but here we have gone up to 12 weeks. And if the patients had endophthalmitis, they typically undergo vitreous and the Equistap with simultaneous intraocular antibiotic injection. And serious patients who got a severe cases, they undergo vitrectomy, and they are all sent for culture. So if you come to the analysis, we have looked at the primary outcome is the post-operative endophthalmitis rate after cataract surgery in 4 different AHUs. Secondary outcomes is we also have compared the methodology and the patient's ability to pay as well. After 450,000 surgeries, they were all distributed across about 4 AHUs, approximately about 93,000 to 128,000 groups per group. A total of about 74 cases were diagnosed. And so if you look at that, there are about 74 cases of endophthalmitis, roughly about 0.16%, or maybe roughly about 2 per 10,000 or 16 per lakh of surgeries. Of this, only about 20% were culture positive. Rest were all about 80% were culture negative. There is a trend which we see after starting the use of moxifloxacin. Before that, it used to be around 35 to 40% used to be culture positive. But after the starting of using of moxi, the culture positive cases have significantly come down. So this is probably the main slide, which if you look at it, the patients, the 116,000 patients or 116,000 patients were operated in operating rooms fitted with laminar airflow HEPA filter. The incidence was about 0.13%. And where we had a central air conditioning with HEPA filter, nearly about 128,000 patients are operated, was 0.016%. And there where we had central air conditioning, but without any HEPA filter, about close to 93,000 patients were operated about 0.017%. And the split air conditioner without HEPA filter is about 0.019%. And if you see, look at the confidence interval, it's very narrow and there was no statistical significance even with this volume of patients we can see. And this is what we felt that this is very important, that for each of the procedures, because there is a difference between phaco and small incision. So we wanted to look at whether there is any difference among phacoemulsification operated in different settings. Here again, we have not seen a much difference with group 1. It's about close to about 0.01%. Whereas similarly, even in split air conditioning, we got the same rate. Whereas with the central air conditioning, it was around 0.015 to 16%. And if you look at the small incision, the numbers are high. And again, it is all equal in all the 4 groups, varying from 0.16 to 0.21. So, and again, if you look at the paying patients, the rates are very low. Whether whatever be the group, it is 0.01% almost across all the groups. We don't see any big difference among the paying patients. And if you see the non-paying patients, it is the laminar airflow group, it is around 0.015%, whereas all the others is about 0.02. So if you, all these rates were not statistically significant, whether it's a phaco, if you compare the phaco done in different AHUs or manual small incision or a paying or a non-paying patients. And again, we feel that all these confidence intervals, if you look at it, they are all very narrow, so suggesting there's minimal variation in the true event rates. So this again, just to go back. So this is the rates. So as we found, all this statistical analysis, we did not find no statistically significant difference. Normally, we look at the power of the study. Normally, we would like the power of the study to be around about 80-85%, but being a retrospective study and where the incident level is very, very low, where we have about 1 or 2 patients per 10,000, the post-hoc power was only 5%, indicating very low likelihood of detecting such a minimal effect. So even if you increase the sample size to even 1 million surgeries, we may not be able to see because the number of cases are very, very low. So there is a very low likelihood of detecting such a minimal effect when the incidence is such a very, very low level. But what we feel is that given the sample size, which we have a large sample, the true difference is statistically negligible and should be clinically, and whatever is irrelevant. Just to conclude, I mean, the laminar airflow with HEPA filtration is widely implemented for the purpose of improving the operating room air quality. Many hospitals, surgical centers, regulatory agencies, as we heard, mandate this along with positive air pressure, number of air changes per hour, air velocity, all of that we had. Mainly to filter the microorganisms and the particles. And specifically reducing airborne microorganisms does not necessarily translate to decreased post-procedural infections. What that comes out of this observation, whatever we have seen, this is not like a prospective study. We are not. This is what we have observed in all our different surgical facilities. And as I said again, we have not seen any significant benefit either with laminar airflow or HEPA filtration with regard to about post-operative endophthalmitis rate. It is true for both the subgroups of SACS and FAKE, and also with the different type of patients. And interestingly, there was recently a paper was published about 5-6 years back from Shroff Charity Eye Hospital in Delhi. They have compared their tertiary hospital in Delhi with the 4 secondary centers, wherein they have done about the equal number of surgeries were done, about 40,000 in each of the centers, where again the endophthalmitis rate was similar, like 0.042% in the tertiary versus 0.039 in the secondary centers. Similarly, the Kaiser Permanente, they have done about 13,500 surgeries, an office-based surgery without any laminar airflow HEPA system. There again, they did not have any endophthalmitis in this 13,500 patients. So, I mean, these 3 studies now shows that the post-operative endophthalmitis rate is no higher when were not used. So whether you use it or not, it's not going to really contribute to that. But what we had seen, in Aravind, we track these endophthalmitis rates on a regular basis. We have the meetings every 3 months and also annually. And if you look at this year 2011, we had done about 220,000 off of what we do, and we had about 188 patients at that time. And the post-operative endophthalmitis rate was like 0.084%. And then we had done several things. We had gone towards vacuum-based autoclaves, double-door autoclaves, segregating sterile rooms, and many other things. But that was able to bring it down only by 0.01%. To from whatever efforts we took, we went from 0.09 to about 0.08 or 0.07. But the year when we introduced intracameral moxifloxacin in 2015, it drastically came down to about 0.02%. And we are able to sustain that all these years in spite of the increasing volume, even though it has become double. For example, if we had not adopted it, and the volume has become double, probably we would have ended up with not 79, but with about 400 endophthalmitis last year. So this is we were able to see a significant difference with introduction of the moxifloxacin, but not with our newer hospitals with newer operating rooms, even though they theoretically said to decrease the risk by reducing the exposure of the surgical site to cross-contamination from airborne microbes. So, I mean, ophthalmology probably maybe more, probably the infection may be more through the surgical supplies like the solutions and the viscoelastics we use or the intraocular lenses, cannot be from the airborne, which may be probably appropriate, can play a role in orthopedic surgeries or surgeries where there involves making a large opening and skin incisions where the contaminations can happen, but not in cataract surgery where the incision size is very, very small, and it's also very close to chamber is what we have. And again, we had done, there are a lot of studies have happened during COVID-19, which showed that there's a minimal risk of aerosolization of microorganisms from fecal-emulsification. That part of time, many of these things happen. And again, we also know there are many mRNA studies of endophthalmitis cultural isolates have identified the post-operative endophthalmitis to be caused by bacteria from the patient's own ocular flora rather than from airborne contamination or other patients or staff. So we also had a lot of discussion about the number of people in the room. Now, we also have done a study looking at the particulate count in our operating rooms at different points of time, starting from morning 7 o'clock, 9 o'clock, 11 o'clock, 1 o'clock, 2 o'clock, all of that. But now what we interestingly found is it's very low in the morning and the evening and higher in the in between when the number of people are more. So we saw a correlation between the number of people in the room rather than the number of door openings or other things. So by end of the day, also that operating room where we checked the same room, whether it had a HEPA filter or had a split AC, showed the same trend. I mean, whatever the trend we saw in the rooms fitted with HEPA filter, the same trend we saw in a place with the split AC also. So again, I just want to say that whatever data we have indicate there's a lack of statistically significant evidence supporting the benefit of HEPA filtration. So that is probably the conclusion of our study. I just leave it for discussion with all of you. Thank you.
Thank you, Dr. Adiyar, sir, for this wonderful paper. It's definitely a landmark paper which has made a lot of talk and ophthalmic circles. I have two questions for you, sir. So just an observation. So universally, all your cases had an intracameral moxifloxacin injected at the end of the surgery. So can I say that this would be the main factor which has caused the reduction of the endophthalmitis rather than attributing it to the ventilation? Because this has really masked the result.
Yeah, possible. So, but Dr. Kumaran, even in earlier days, we have not seen any big difference between the operating rooms. So, but all these data which came with laminar airflow all came after we started the practice of intracameral moxifloxacin. So we don't have data for HEPA filter, the laminar airflow with HEPA filters. But if you look at other theaters, central air conditioning with HEPA filters, we did not see any big difference. So when we did this study, for this particular study, we looked at the 2023 data. Then now we also looked at 2024 and earlier 2 years data from our hospitals. We had seen the same similar trend. So not this year alone, but the years before and after that, we also see a similar incidence of infections.
Can I ask a question?
Yes, Dr. Sujata, I think. Yes, Dr. Sujata.
Okay, I had gone through the study which is published by Aravind, and in that, it's a beautiful study. The large numbers and all that is very impressive. But I just want to know if the patients who had endophthalmitis had any complication on the table. Was it analyzed whether the patients who had endophthalmitis had complications or that part of it was left off? We all know whenever there's a prolonged surgery and we use an anti-vitrectomy, the incident when the vitreous presents, the incidence of endophthalmitis does go up. So in that study, what I read from the journal, there was no distinction. I just wanted to ask her, RDR, if she has any idea about that.
Yeah, as you said, wherever we have seen when there is a complication, the incidence of endophthalmitis is very high. So when there's a PCR, probably the chances, the incidence of endophthalmitis is about 6 to 7 times higher. So it's also true in this period, 2023 also, we have seen that same. So, but the number of cases may be very, very low. The number of patients who had a complication and had endophthalmitis, the study may be very low. So.
I think Sir actually highlighted all the strengths and weaknesses of the study wonderfully. So one is it's a large data set. So that is a huge strength of this study here. And second is being a retrospective. So that's when, inputs on a prospective changes which happen intraoperatively would probably not be as complete as you would like it to be. So that you need a prospective sampling. And as Sir rightly said, when incidences levels are as low as what we are having in current stands of microsurgical systems, even if you do a prospective sample calculation, that's probably not going to be a realistic figure which we can probably achieve even in some of the highest volume centers, even if you put a lot of centers together here. And again, as we all know, endophthalmitis has multiple confounding factors, multiple variables which enable its occurrence here. We all know that it's probable the largest contributor is going to be the fluid systems and those instrumentations which we handle during our microsurgical procedure itself here. So a prospective study in this is something which would be desirable, but it's probably going to be more challenging and is not going to be a feasible aspect which we are going to be looking at. And these points were rightly highlighted. And also as a primary outcome and the secondary outcome was looking at only endophthalmitis occurring in OT systems which had this various air control systems fitted here. So that was the primary and secondary objectives here. So, we need to analyze the results in these space. And as we, Sir, rightly concluded, statistical evidence is probably not very definite, given that, India is a wide country, we are still operating and we are fortunate. But then one question, Sir, which I would like to ask you. So in the current scenario of medical legal, instances cropping up, if you have an endophthalmitis occurring in an OT system where the recommended OT norms have not been fulfilled, how safe is the surgeon and the practitioner in defending himself or herself?
I'll go only by evidence. So that is where we have generated this evidence for the Indian ophthalmologists or no ophthalmologists anywhere, so that they can defend themselves to show that even with even the split air condition may not be probably the appropriate one as per the statutory norm, but we have shown that doesn't contribute to endophthalmitis. So we also would like to generate some of the evidence so that which probably have to be taken into consideration when some similar regulations are formed. I mean, putting up a theater with a laminar airflow with HEPA, all of it's very, very expensive. It may not be possible for all the ophthalmologists practicing in many of the rural areas or even in a tier 2 or tier 3 cities. So, I mean, the only point I would like to say that we need to focus more on sterilization. How do we monitor the sterilization with the appropriate indicators? And how do we invest on a good vacuum-based sterilization? How do we ensure segregation of unsterile from sterile? And as Dr. Nirmal mentioned, unidirectional flow. All of that probably will contribute more to prevention of endophthalmitis than these expensive systems. So I mean, wherever it is possible, I think we should do it. As we in Aravind also, we believe in that. We should probably adopt it. Even though I've showed that it's not statistically significant. If you just look at the numbers, the lowest is with the laminar airflow with the HEPA filter is the lowest. But they are not statistically significant. That's what I would say. Here we have about 12 or 13 patients per lakh. Here it may be like 16 or 17. So in the other group. So wherever possible, I think people should make the progress and adopt what is scientifically correct, which is the interest of the patients. But I'm not sure whether that should be mandated at this point of time.
Yeah. Yes, Dr. Radhika, you have a point.
Yes, I just wanted to make 2 points. One is really commendable that they had access to this wealth of information and that with their partners and collaborators, they were able to generate this data set. as has been said, it is a valuable source of information, and it is a kind of a reference point that can be used for various purposes. As a kind of a validation, and as Sir said, a kind of a protection as well. Because sometimes one just goes in a one particular direction and assumes certain things. It's not that one should not follow the whatever. Recommendations and guidelines are there for laminar flow. It's just that if you really look evidence-based and scientifically, then you can generate, you just have one source of data. However, as Dr. Ravindran very nicely covered all the, not one would say the sort of the limitations of a study of this kind, the number of endophthalmitis cases being very low. And this is going to always be a challenge forever, any study which is done on endophthalmitis. And also, as many people, including Vanati, have mentioned, that for ophthalmic infections like endophthalmitis, simply airflow is not the only factor. There are so many other variables. Unfortunately, with the Aravind Eye system, they have that standard protocol and sterilization of the instruments and the fluids, etc. But I would say one thing, if by any chance did they have a policy of doing air culture plates. So there is a protocol we follow that we have, once a week we put the culture plates in the OTs and we check that as well. So that would be another area, because I understand that endophthalmitis is very less and there are many other factors which we obviously are happy that endophthalmitis is less. But can they look at their data for the rate of positivity of the culturing of the air, if they've been doing it, that you put a culture plate, you expose it to the air for half an hour, and then you check. So that may be one thing worth looking at. And that, I have a feeling, will show that the laminar airflow is better. Now, one may argue that the endophthalmitis is not statistically significant, but we don't want, it's going to be virtually impossible to have a kind of a good such standardized data set to really prove it. So we have to use our common sense. Before that, we had all the scientific basis as well as the legal and the statutory basis. So I don't want people listening to this program to misunderstand and think that it's not necessary. So the goal is to have the best possible scenario with the filtered, HEPA filtered air, at least, if not an individual AHU for every OT. And I would really be interested to know if they have this data about the culturing of the air.
Yes,
They
madam.
have that information.
Yeah, we do the settle plate method every 15 days earlier, but after seeing the results, we just now do it once a month. And then we make sure that we have the standards. The bacterial colony should be less than 20, or we should not have any fungal colony. So if we find anything, then we do some kind of fumigation. But I can say that 90% more, 99% of the time we may not have that. But when we see, then we take extra precautions, extra fogging for 1 or 2 days, then repeat it and then start using that thing. But it's a regular practice. But we don't do it weekly. Earlier it was once in 15 days. Now it is once in 30 days.
Yes, Dr. Savitri.
Thank you.
Yeah, thank you. Thank you, ma'am, and thank you, sir. Dr. Savitri.
Thank you, Ravi. Very nice. I read the paper just before your presentation. I have some question about the all the ORs which do not have laminar flow and HEPA filters. Fogging must be a routine.
Yes, it's a fogging. We do it once a week, and where we take out all the instruments from the theater and then we do a fogging. That usually typically on a Saturday, and it is closed till the next day evening, Sunday. And some days, sometimes when we do a very large volume of surgeries on Monday and Tuesday, then again we repeat it on Tuesday or Wednesday evening. Otherwise, typically it is once a week where we don't have laminar airflow.
Yeah. The second question was about the culture positivity. You have only 14 cases, I think.
Yeah.
So did you analyze only those 14?
Yes, yeah, I have not shown here the PCR. So wherever we are able to do the PCR, then we do it. There again, the positivity is around, where it is culture negative, and we do a PCR, maybe like 30% will be positive.
But in the tables, I find that the numbers are more where you have analyzed the FACO and non-paying. The numbers of POE are more there, but where it is, why there is a variation in the numbers in the tables?
No. So the table we have put up now, we have seen overall what is the infection rate with the different AHUs. Then we looked at all the FACO emulsification, and then these 4 different settings also we looked at it.
So, but everywhere culture positive has been considered as endophthalmitis.
No, everything, both the culture positive, culture negative, all were included. It's only based as endophthalmitis is only clinical diagnosis. We don't go by the culture.
And 74 cases.
74 cases.
Okay.
Yeah. No, if you had seen that slide, I showed another rate, you must have seen what 77. The 3 of these patients were other surgeries. So, like, the patients were undergone secondary IOL or patients are referred from outside, those cases. But primary cataract surgeries, we had about 74 patients.
So I have another question for you. I understand it's a different question apart from the paper. Can we extrapolate the results of this paper to other ocular surgeries like orbital or corneal transplantation, where the wound size is larger and the duration is also larger? So do you also recommend a similar airflow system in those surgeries also? Because according to HOTA, it always mandates a system with a HVAC system in place. So the septic theater norm has also been taken off, and you can centers with a single theater with a HVAC system in place can get a HOTA license. But now with this standard coming in place, would it be difficult for smaller hospitals to follow this norm? They should have 2 theaters, a septic and a non-septic OT.
We also track the endophthalmitis rate for all the other surgeries, corneal surgeries, glaucoma surgeries, retinal surgeries, and the injections, especially. So what we find is next to cataract surgery, the commonest where we have endophthalmitis is the vitreoretinal surgery procedures, especially where they have to do multiple times, where they use silicone oil removal. That's one group. The other group where we find where the actually endophthalmitis rate is higher is the post injection, intravitreal injection. So there the actual rates are higher. So then even if you take all precautions, put powder, iodine, everything, still it is higher than what we see in the cataract. So which again shows that probably it goes from the patient's
ocular
reflex, so preoperative.
So congrats, sir, on a landmark paper. The huge numbers are difficult to replicate with the prospective study.
Yeah.
And even if it's multi-centric or multi institutions over many countries, very difficult to get these numbers for a prospective study. So one thing is not much of statistics significant between the 2 groups, in between the 3-4 groups, and clinically irrelevant differences and extremely low baseline rates. So is it because of the proper process control, or it is because of the type of surgeries we have now changed to? Because from an open surgery, we now shifted to a closed phacoemulsification or even a small incision surgery. And there are also major variables, so that very difficult to standardize the groups. Like all cases had a preventive method incorporated, that is the intracameral moxifloxacin. So in this regards, how do we compare the results with such low numbers?
No, that's what I was saying, that it is very difficult. So I had a discussion before this meeting with our biostatistician. So now, when any study, for it to be effective, we want to have a power of the study, we call it, to decide on the sample size, around until 80% or 85%. But here, it's being retrospective study. There is a method to look at what is the power of the study. It came out only as 5%. But we have to go by the volume of the surgeries that have been done. One. The second, I understand from the statistician, why they say it is statistically not significant is the narrow confidence intervals. According to them, based on these two things, we can say that it is not statistically significant. So because it will be very difficult, whatever be the volume, even if you take million surgeries, if the incidence is going to be the same, 1 or 2 per 10,000, still we may not be able to get the statistical power to say that, to have a clear cut saying that it is to see the difference, but the incidence level is very, very low. So, and again, as you said, it is the development of the microsurgical techniques, a lot of the things and the precautions we take, especially using the povidone. Now we know that at least it has to be there for 3 minutes. We do it inside the theater and outside the theater. So all of that, I think, has contributed to the low level of ophthalmitis, and again, strict monitoring of the whole sterilization process. All of that also has helped us to prevent any of the cluster, known or unknown cluster infections happening in the system. So,
just to add on, Dr. Nirmal, I think Sir did highlight that in a retrospective study, we don't look at the power. So a power is always prospectively calculated because it's the sample strength based on which you're really going to be deciding on the power of a study, and to hold it statistically valid, you would look at something above 90%. Is when you would really say that it's going to be a high evidence level or evidence-based study here. So I did post this question once I read this and shared, took in the inputs of our current head of the biostatistics department of AIIMS, and also our prior biostats department, who's current honorary chair of the ICMR biostats team as well. I did see Dr. Ardia's biostatistician also logged in briefly, I think, at the beginning of the...
Yes, I wanted to...
Yes, yeah. So, but I didn't want it to make it a head-on, because we know that this was a retrospective study. So we are not talking about power here. And Sir rightly said that we won't have numbers, even though this is an amazingly large data set which we are looking at. So just to give an input for all those research minds who are probably listening to this here, and this comes in from Professor R.M. Pandey, who is a fantastic biostatistician. So just an input is, when you have a very large data set such as this, using what is known as the propensity score matching system among the 4 groups. So again, these are not mine. I'm not a biostats expert here, and I always lean on to both Dr. Maruf Khan, who's our head, and Dr. R.M. Pandey for all the IGO statistics. Whenever I need to cross-check, I am always at their doorsteps and poking them every day to get back on the stats adequacy of a particular paper. So this is something which I learned, and I would love to share it with you, that there is something called the propensity score matching system, which you can apply to large data sets such as this, which have 4 groups, and this would probably remove or mitigate the confounding bias which can occur in a retrospective study set, and especially in a disease such as endophthalmitis. We are looking at many confounding variables here, and this would probably give you a decision or an inference which could be simulated to that of an RCT. So this is what Dr. Pandey's. I'm sorry I was not able to reach out to him. I wanted him to join us today, so that he would probably be able to explain this. Probably we'll have more on statistics, and when he comes in, he could probably detail more to us on this particular thing. But I think wonderful learning points, Dr. Ravindran, and a wonderful way at which we learn so much on keeping large data, looking at multiple facts, and how we could probably apply this to various surgeries other than just cataract surgeries as well. And we all know endophthalmitis in microphthalmic surgery is largely, probably dictated by several other factors. And the HVAC is probably just one of those which are probably lower down in the priority. But then when you're looking at international standards, you will still want to have them to keep the protocols complete here. And Kumaran, would you like to take it forward? Yeah.
Dr. Samina has something to say. Yes, Dr. Samina.
I just wanted to sort of quickly ask RDR sir and Dr. Nirmal here is that in this study, the only variable was that whether the air handling unit with the lamellar flow is there or not. Otherwise, everything is across all Aravind centers is standardized, right? The quality of the water, disposables, the intracameral drugs, the type of sterilization. So is that correct, RDR sir, that everything is standardized except for this variable?
No. We use exactly the similar system. So to make sure that the standards are followed. So
yeah. So Dr. Nirmal, what do you think about this part of this equation that everything as is highly process driven and standardized? How difficult or what do you think about this? How other hospitals can emulate this?
No, again, what the standards prescribe that to reduce variability, reduce the risk, you need to reduce the variability. In a highly controlled training center like Aravind, it is possible with a trained set of people with good monitoring and surveillance and data to back up. But it may not be possible in smaller centers with variable human factors. So if we can standardize the structure, so that will actually protect the variabilities in the process. But we don't have a proper structure in place, then we need to put our efforts to strengthen our processes, strengthen our monitoring, strengthen our surveillance system, and of course, the usage of the infection control mechanisms like povidone and oxyfloxacin. So all these comes into the picture. So all these put together can give us good results, and not only a basic environmental system. So environmental system do help in reducing the basic factor, to reducing the root cause, reducing the risk of infection, reducing the strength of microorganisms, or making the microorganisms unviable by giving a good environment. But of course, in a wide geographic variation like our country, where extremes of humidity, extremes of climate, extremes of climate variation happens, and of course the variable training background of our people. So not only the doctors, but also the support staff. So with that in mind, we need to have many levels of standards, not only the infrastructure, but also the process standards has to be systematically improved.
Thank you, Dr. Nirmal. And while I'm at it, I wanted to ask Mr. Vinod, who is an engineer and expert in AHU, that do you think at any point of time the AHU can also fail? Or what are the things what an organization should keep in mind about having an efficient air handling unit, the pain points?
Thank you, Dr. Zamina. Yes, AHUs can fail, obviously. We need to make sure that we buy the right product at the first instance. There are various kinds of air handling unit suppliers. There are various kinds of types of air handling units also. There are air handling units that are generally used in the commercial applications, which get used in the hospitals, which should be avoided because healthcare systems, when it comes to ASHRAE or BI British standards, they have a specification for the construction of an air handling unit. The construction of the air handling unit is so critical because the entire energy is happening within the air handling units. That is what is coming as air finally, though it says air, but then that air handling unit is an important part of the theater or any procedural area for that matter. So the specifications that derive the selection of an AHU is very important from the beginning of the project. Selection of the vendor is very important because not every AHU air handling unit manufacturer manufactures healthcare air handling units or air handling units which are specific for pharmaceutical applications. I can very well, in this forum, I can say Aravind specifications are the best in the world, which say how the AHUs have to be, made or manufactured. That itself is the first aspect of AHU selection. Number two, as Dr. Ravindranath said, or also Nirmal doctor said, good maintenance is important for us to make sure that it doesn't fail. Third part is to have a contract or maintenance contract with the vendor to supply the motor. The only thing that could fail in the HU is the motor. The next thing that could fail is the heaters, which are taking control of the humidity from 60 to 55 or 50 it controls. So there that also can fail because electrical components can fail. That is like one of the doctors did mention, the humidity levels are nowadays very high. Motors can fail because of condensation happening. So we can make sure that the vendor suppliers are able to give us a motor quickly as soon as it fails. But what happens, doctor, is if you have a good maintenance team, you can actually identify the deterioration of a motor because of its characteristics that you measure while it is working. I like how you measure the condition of a patient. You can once you monitor the data of an air handling unit, you can definitely identify whether it's going to fail or not. So that's where the preventive maintenance and the predictive maintenance comes into play. Predictive maintenance is one thing which tells you in advance that the motor is going to fail. So obviously your breakdowns are going to be very less. So that's the dependence on the air handling units. Next important thing is a compressor, which gives the cooling part of it. So there again, make sure that the maintenance is very good, and good manufacturers are important actually. Because what happens is sometimes money negotiations, we do not know how these guys manufacture the units. So when we keep on squeezing the price, obviously there will be some kind of a dilution in their specifications, which could lead to a failure, premature failure, which then we are going to suffer because in the middle of a surgery, you don't want an air handling unit suffering or no cooling because the compressor is failed. Third part is, Dr. Samina, is the good electrical supply that you provide to their handlers is very important. If the voltage is supposed to be three-phase, it should be 415 volts plus minus 10%. If the voltage is very low or very varying voltages, it could affect the system. So if you have if you have your organization in an area where the voltage stability is not there, you might as well have voltage stabilizers to stabilize the voltage, because it's not only the air handling units. There are so many equipments that you have where the voltage stability can have a problem to the failure of the equipment. So that is also an important part of it. I think I've answered your question.
Sir, can I ask one question?
Yes, madam.
Yeah, so I just want to know how often do we have to clean the filters, the pre-filters, and the duct? What is the normal specification?
Duct cleaning is not mandatory, doctor, because what happens once you do your pre-cleaning and the finishing of the commissioning process, normally you don't need to do that because you're in a very sterile atmosphere. Unless you find that a growth is there, you need to clean the ductwork. Cleaning the ductwork is generally done for kitchen ductwork where there's a lot of grease coming in because of the cooking part of it. That's where the regularity is very, very high. The frequency is very high. Then coming to the filters. Again, as the typical way at Aravind they are doing, that is the most recommended way of doing filter cleaning. When it comes to the microwave filters, they can generally be only air. You can only blow air to that because they are a kind of paper kind of material which can get torn off. It's the pre-filter that can be washed. As we know that there's a pre-filter and then a microfilter. The pre-filter can be washed, dried, and then used. Then the other filter generally is not cleaned. You can blow the air on top of it. Third part is the coil. The coil cleaning, nobody bothers about it. See, when water is sticking onto a particular metal surface, there's a biofilm that forms on it. So generally what we recommend is to have a UV light on the facing the coil, which will disinfect the whole coil for any microorganism. Because post the coil, it get into the airstream, and if you do not have a HEPA, it goes directly into the room. So that is one thing which you can look at. I hope I have answered your question.
Pre-filter, how often do you clean? Once a month or
Twice a month is better because
twice?
what happens is, like again, doctor, is the zoning of the whole theater is important. It's not just the cleaning of the filter. If you have a semi-sterile corridor connecting a theater, you have outside air coming in, or the AHU, if you're keeping it in a place where it is dusty, it will take a lot of dust. So generally, what happens when the fresh air component is there, it will be lowered onto the floor level. Generally, what happens, you have to take the duct to a higher level so that it doesn't suck the air from the floor level, so that that gets choked very faster. So it's basically the location of the air handling units, the zoning of your this thing, that it is generally specific to your own hospital. You can decide that. If it's getting choked, the airflow also will reduce. It will also reduce the positive pressure inside your room, because once the airflow gets drastically reduced because the filters are choked, it gives you very low positive pressure in the room.
Okay.
That is another factor.
Okay. Thank you, Doctor.
Vinod,
Yes, sir.
one major complaint is the cost of installation and maintenance.
Yes, sir.
So what is the industry taking? So where are you up to now? How do we reduce the cost, both installation and maintenance?
So there are two parts to it. Any air handling unit system, when you buy, generally it will have a lifespan of 15 years minimum. So if you have a commercial air handling unit sitting in a healthcare system, its lifespan will get reduced. So then obviously you'll have to opt for a healthcare air handling unit, which can, because what happens in healthcare is, the temperatures and humidities are a major factor. I'll just give an example. When you are having an office atmosphere 24, 25 degrees, the humidity level is always comfortable. But when you start dropping the temperature, when you look at temperature, there are two temperatures as such, the dry bulb and the wet bulb. When you chart it on the psychrometric chart, you come to an idea what the relative humidity is going to be. So what happens is, when the dry bulb gets lower and lower in an operation theater, the wet bulb also gets lower. The wet bulb starts getting closer to the dry bulb, wherein which the moisture content starts forming. We come to a dew point temperature. This doesn't happen in an office atmosphere. But unfortunately for us, in theaters where we drop the temperatures to 21 and 20, and when it comes to super specialty, we go up to 16 and 17, obviously the wet bulb is too low, wherein which the humidity is extremely very high. So when you select a healthcare air handling unit, the whole body of the HU is able to take these low temperatures and high humidities for a longer period of time. So you don't get condensations on the, if you see many of the air handling units, you will see water on the outside of the body dripping and falling on the floor. That will not happen if you have a good healthcare unit. So that way, money-wise, the return of investment comes in for good quality healthcare HUs, wherein which your lifespan also comes in. You get the return of investment coming in on the first phase of the supply itself. Second is to have a good maintenance contract with the vendor, so that you know that you have a system which is not going to fail because you have a good maintenance mechanism. Obviously, compared to the split AC, this is expensive, but looking at the overall, as Dr. Ravindran said, is AHU is one component of the entire zoning of the operation theater, but that could contribute largely if there is a contamination issue, which then at that point of time cost is going to be very large.
Okay. Yeah. Thank you very much, Mr. Vinod. I think very, very vivid and elaborate discussions to help our understanding on laminar flow systems here. Any remarks from you, Dr. DC?
Thank you, Dr. Vanati. Actually, we had a total overview of AHUs and laminar airflow by Dr. Nirmal and Vinod. And it was an absolutely fantastic landmark presentation by Dr. R.D. sir, where the numbers just speak for itself. But at this point, I would like to say, if there is an environmental failure where there is contamination, we'll land up in a cluster, not sporadic end of that. Sir has already presented huge data with 1 or 2 per 10,000. That is all sporadic cases where probably the source. So somebody asked about the medical legal aspects. When there is a sporadic case going to the court, the patient has to prove that we were at fault. But if it is a cluster, the hospital has to prove that we are not at fault. because it is iatrogenic. So that is something that would happen. So more important, I have seen, being with the adverse event committee for 3 years, I've seen all types of clusters. But environment, one hospital had fungus on the walls and everything because they were not doing a proper surface cleaning or fumigation. So that they are themselves the cause. Otherwise, it is usually the fluids. As Dr. Savitri Madam said, it is faceted. It need not be only the environment, but if you have a proper protocol, maintenance, surface cleaning, and in between cleaning, then it will not be the cause for end of or cluster end of. But the other things like RDS sir rightly said, sterility. See, the thing is, we may have protocols, but you need people to sustain and do that, and they must take ownership. If supposing I don't touch the microscope and continue assisting, that is going to become an end of. So I must take my ownership, go wash, scrub up again, and come. The doctor, whatever is said and done, the operating surgeon is primarily responsible at this point in time. The protocols should be taken care, and they should be having there should be some kind of daily checklist, weekly checklist, and proper recalls even if one thing fails. These are the ones that are more important. Of course, the environment is there, but only point from my side is NABH mandates SIPA filter for accreditation. Whether these kind of data, actually, though sir said it is retrospective, the study is still going on as prospective. I'm sure sir will agree. We are continuing to have data, and the infection control meetings of Aravind Eye Care System, they are not just presenting the numbers. Each case, root cause analysis, every aspect, every fluid, everything is undertaken to analyze and presented. So I'm sure we'll have some point of time where Nirmal would take it forward to NABH also, because in our country, the 70 to 75 lakh surgeries done per year, not many hospitals can afford a AHU HIPAA filter. And these are the small points I thought I will take. Thank you, Adya sir and Nirmal and Vinod, for your wonderful inputs.
Yeah. Thank you, Dr. TC.
Thank you.
Yes, Dr. Ravindran, would you like to add on to anything?
No, I just want to ask Mr. Vinod whether he's got any recommendation for doctors who have split air conditioners. I mean, is there any standalone air purifier which has got a HEPA filter? Will it help in such systems?
Sir, the volume that we have, the number of air changes that we need as per the theatrical conditions is high. So having a small purifier will not really be able to purify the entire amount of air volume inside the theater. That is one thing, sir. Secondly, the humidity levels are always high in the theater. The air purifiers will get choked very fast with humidity. There will be fungal growth coming inside those filters as well. Then we'll have to run a maintenance schedule for that. So that will become a challenge for you, sir, slowly.
You don't recommend them?
No, sir, because Pondicherry, Chennai, Kochi, Mumbai, Kolkata, the humidity is very high, and extremes of climates are happening. Like how the ambient temperature is increasing, humidity is also increasing, sir, annually. So that could add on to our burden of the load on the air handling units also, sir. I hope I explained.
No, yes, because that is being marketed to many of the doctors. I think this message will clarify.
It's oft-repeated question, sir. They'll say this is the AHU we have with all the filters available. So close this non-conformance. But they don't really understand this small so-called sterilizers actually complicate the system. A poorly maintained HEPA filter or LAF is worse than good, well-maintained split AC. So we shouldn't complicate matters further by adding all these elements.
And it's an important message we share.
Yes. And one more thing is, since Chandru opened this up, engineering control is 1 out of 305 objective elements we have. So there are 304 objective elements for us to follow, then focus only on this 0.5 objective element. Right. So there are so many ways of controlling the parameters. Like Aravind is blessed with the excellent process control mechanism, but not others who have certain structural and process deficiency. So only focusing on one objective element is not really good. We can focus on 304 elements and make our processes more stringent, less variable, and reduce the risk so that our quality automatically improves.
Yeah, well said.
And
Well said, Dr. Nirmal. I think it could not have been worded better. And I think the message for today is to look at the environmental influences in the OT on infection rates here. So that's what we were looking at. And infection rates depend on several other variables here. So how are we probably going to correlate this with whatever evidence level on big data on a retrospective study is what we looked at. So we are not really here to say that, this is good or this is bad, but as all of us have reiterated, we need to have the norms in place, the norms as required by statutory systems and how we compliant to it. But beyond that, we as surgeons, we as ophthalmic healthcare providers, we need to hold our protocols and our levels of commitments high, which goes beyond just environmental influences in the OT. This is one of the many, but this also needs to be taken care of. And that is what we are debating on today. And the evidence level it holds to the incidence or the occurrence of endophthalmitis in cataract surgeries. So that's what we learned today. And I really thank all of you for taking out your time on a workday evening to share your thoughts and your inputs and really enhance our knowledge levels on this particular subject. My particular thanks to the speakers, Dr. Nirmal and Dr. Ravindran sir, Samina, Vinod, Savitri ma'am, Kumaran, Gagan, Prasanna, DC sir, and Dr. Sujata and Dr. Radhika Tandon. I'm sorry that the AIOS office bearers are all traveling at this point of time, couldn't join us. But thank you all for logging on and keeping us glued to the sets here. Yes, Dr. Radhika, any closing comments? Yeah, okay. Thank you very much. Thank you all. And wish you all a very good night. And hopefully we'll meet together to take this forward with different discussions on OT sterility norms. Thank you very much.
Okay, thank you.
Thank you so much.
thank you, sir. Thank you.
all.
Thank
Very
you.
much.
Thank you.
Thank you.
Thank you.